Hello. Okay, we are live. Apparently we are streaming live on YouTube, so I know we're full of high technology here at the George Institute. Welcome everyone. I'd like to welcome you here to the George Institute for this seminar, which is proudly supported by CRA, the State Insurance Regulatory Agency. I'm not going to read out the whole biography, but we are very grateful for CRA to sponsor this. As you know, they're the New South Wales Government regulator of New South Wales workers' compensation insurance and motor accidents insurance. So thank you so much, David, Andrews and Sarah. I do, of course, want to acknowledge the traditional owners of the land that we're meeting on, the Gadigal people of the Eora Nation, and pay my respects to elders past, present and future, and to any Aboriginal people that may be here today. So it's a fantastic opportunity. It's a great crowd here. Thank you so much. Friday afternoon, who would have thought we would get so many people interested in road safety? But it's our fantastic international guests that we've got here. We're very fortunate to have Andrea Geelan here from Johns Hopkins and also Alison McPherson from York University and a range of other road safety researchers. As you know, the George Institute is now, well, you may not know, but we're now affiliated with the University of New South Wales, and we thought what a fantastic opportunity to showcase all the great work that's being done in New South Wales from researchers at the University of New South Wales. And of course, we've also very pleased to have Bernard Carlin here, who's the Director of the Centre for Road Safety. So that's this afternoon's activities. We are basically getting leverage from the recent Australian Injury Prevention Network conference. So AIPN has brought Andrea out as a keynote speaker, and Alison was also out here at the AIPN conference, so we're very grateful to have them up here in Sydney. So first up, we have this afternoon is Andrea Geelan. So Andrea is Professor and Director of Johns Hopkins Centre for Injury Research and Policy at Johns Hopkins School of Public Health, and she's a behavioural scientist. You've all got her biography there. Clearly she's a very well-known, highly experienced researcher who's been awarded, had many awards, and she's got many projects on community and clinic-based programs to reduce home injuries, pedestrian injuries, and a range of other injuries. So Andrea, welcome.
Thank you. Thank you very much for the invitation to be here and for that nice introduction. I'm really excited to be here with you all and hear all the great presentations that are lined up this afternoon. And the one that I'm going to kick off with is just doing sort of an overview of what we've been doing in Maryland and Baltimore over the years to promote child passenger safety. I want to first introduce you to the center that I represent. It's our 30th anniversary year at the Johns Hopkins Bloomberg School of Public Health. We have a faculty of about 20 people across many different disciplines who we have a three-part mission to conduct research, and we're very committed to the translation of that research as well as to a training mission. So that's us, and we welcome any kind of partnerships and collaborations going forward. So I'm going to be talking about one aspect of motor vehicle safety, but I thought I would start with the larger context just very quickly to show you in the United States, what you see here is the green line are the vehicle miles traveled from 1925 until 1995 that increased dramatically, while the blue line shows you the 90% reduction in deaths per million vehicle miles traveled. So this is a huge public health accomplishment. In fact, the Centers for Disease Control and Prevention named it one of the 10 best public health achievements in our country in the past decades. So when we think about what, and this is, I'm sure, similar here as well, when we think about what accounts for the improvements that your country's seen, that our country's seen, we can see that we really focus on changing the environment and changing individual behaviors. And so I'm going to focus just on the increases in car seat use and the way we sort of approach that in our experience, just hopefully be of interest or use to you all. And I'm going to do that by talking about some examples from Maryland, which is where we're located. In the state of Maryland, which is a lot like Victoria in terms of size and demographics, but even more specifically specifically, I want to talk about Baltimore, and this is our harbor, not nearly as great as your harbor, but we welcome you to come and see it if you're ever there. We'd love to do that. And so, as I mentioned, our center started 30 years ago, and it started with someone in injury prevention who's known to people who have studied injury prevention as one of the creators of the field in the States, Susan Baker. Her pioneering work demonstrated that infants were at significantly higher risk in a car crash than any other age group. And that information was utilized to help stimulate the passage of child restraint laws throughout the country. So what we did with that was we got this really cute car seat model who happens to be my son. A few years ago, I was at the Maryland State Health Department, and so the Department of Transportation asked the Health Department to develop a child passenger safety program in response to the increasing awareness of the problems. I'm going the wrong way. Oh gosh, sorry. Okay, use the right arrow. Okay, so we, oh, sorry, my bad. All right, so what we did looks a lot like that other slide, only it's not. We started a program called KISS, Kids in Safety Seats, and we took the same theme as what we saw happening overall with motor vehicle deaths by thinking about how did we need to change environments and how did we need to change individual behaviors. So out of the health department, we worked with state transportation and other collaborators to get a child passenger safety law passed, to start car seat loaner programs to meet the needs of low-income families, worked with law enforcement and worked with healthcare providers, as well as trying to reach individuals directly through public information campaigns and patient education programs. So I use that as an example of, again, trying to take a comprehensive approach to making change. And we were quite successful. This is a picture of the governor of our state signing the first legislation back when I guess we didn't have color photography, but it was one of our successes. But fast forward to this century, and I can introduce you to my grandson. What we have now is most kids ride in car seats, but the problem is they ride incorrectly. They either have the wrong seat, it's not placed in the car correctly, or they're not using the car seat consistently. And another big issue that we have is disparities in dissemination. So we have this life-saving product, but who is getting access to it and who is using it? And so in East Baltimore, we have services for low-income families in our children's hospital. This is a picture of the Johns Hopkins Children's Safety Center, which I love being able to present here because when I first came to Australia for the first time in the 1990s, I went on a tour of the Royal Children's Hospital in Melbourne, and they had a child safety resource center there. So in addition to importing your wonderful wine, we imported this great idea of a children's safety center, which now there are 30 children's hospitals or more have them in the States. And so the point of these are that you can get free personalized education and you can get low-cost safety products. And so a lot of the families who we serve are low income and living in an urban area. And here's just a picture of our car seat display inside the safety center. And what we did was an evaluation of it to demonstrate its impact. It was focused also on home safety, and we showed that it was effective, so the hospital has kept it running as a service program. And the most the most common reason people come to the safety center is to get car seat services. So it's one model that is tied to healthcare delivery systems that seems to be helpful. And as I mentioned, that it's in more than 30 children's hospitals, and we have new space now and a replication guide. But the problem was that lots of low-income families didn't want to come into the hospital, and we needed to find a way to reach out to them. So we did that. We expanded on this model in a couple of different ways that I'll run through. A mobile van and mobile technology. So this is our 40-foot truck version of the Safety Center that has interactive educational exhibits in it, as well as access to low-cost safety products. So it allows us to go to the community, which we do in partnership with the Baltimore City Fire Department firefighters. This just gives you a quick look at the inside, where we focus on home injuries as well as car seats. So the firefighters in our communities do the car safety seat checks. So we integrate that with other kinds of life-saving products and education for families. We did a bit of an evaluation of the project. Who do you reach when you have a mobile safety center? Is it better if you tie it to a healthcare delivery system like a well child clinic? And so we found that it was very good in terms of getting people to come onto the van in the community settings. We had a little bit more impact in terms of educational services when we were tied to the well child clinic, but nonetheless, out of 6,000 people, we saw that 6,000 people and 559 products distributed during this 2 years of the evaluation, and about a quarter of those were car seat services. So there seems to definitely be a need, and people are open to getting those car seat services in the community through something like a van. So the second way we expanded in terms of being more mobile is consistent with how things are going today, that we have to use technology. And this was our first foray into using computer technology. And so this was a kiosk that was in the pediatric emergency department where families interacted with it while they were waiting to be seen. And based on their answers to a series of questions, they got a tailored report that came out right out of the kiosk. And so it was a little bit clunky, took up some room in the emergency department, but it seemed to have an impact. We also did an evaluation of it in a randomized trial. And we were looking at home safety along with car seat safety, but we did have a significant increase in the intervention families who were reporting correct child safety seats because, well, I'll show you in the next example. So in terms of the kiosk, as I said, was big and clunky. So we now have the next generation of computer technology interventions using mobile apps. Again, both of these projects were funded by the National Institutes of Health. So the Safety in Seconds version 2.0, uses theory of behavior change and a tailored app to look at 4 different components of car seat use. As I mentioned earlier, the problem is that people have a hard time using the seat correctly, and it's not just simply how many seats did you get out, but is it the right seat for the child's age and weight? Or is it used all the time? Is it in the back seat? And then we have car seat technicians and car seat checks. I think they're pretty universal, and that's highly recommended because of the misuse problem. So those were the behaviors we were trying to address. And the way the app works is that the family completes an assessment on those 4 behaviors and gets feedback. They then have monthly text messages to remind them about the app and also about a portal that they can go to for more information. And then we did a 3- and 6-month follow-up. So this is what the screenshot looks like when you get your report back, and you can see that the family gets a check or an X for each of those 4 behaviors, and they can read more about each one of them, what they need to know or what they're doing right. And here's a copy, a picture of the report. So we tell them what they reported to us, and then what experts say they should do, and then what you can do specifically, sort of the call to action. I won't really go into great detail, but just to tell you that in putting something like this together, it's important that we think about what is the theoretical underpinning of the messaging and what variables are you going to tailor those messages on. And the most important probably is to always have a call to action and a referral to resources for families. So, and we've published this if you're interested in more detail. This just basically shows you how we use theoretical constructs for different message content. So it was quite a production to figure out what the message library was going to look like across the stages and the variables that we wanted to tailor on. So we tested this also in a randomized control trial in Arkansas and in the emergency department at Hopkins again. And we randomized into a attention-matched fire safety group and the car seat safety intervention that I just sort of went through with you. And what we found was that this shows you the intervention group and the control group with the adjusted odds ratios for each of the behaviors of interest. So we can see that using the correct seat, the change in the intervention group was significantly greater than the change in the control group. The intervention group had an adjusted odds ratio of 2 for correct seat, 2.37 for putting the baby in the back seat, and the buckling up always was highly, had a real ceiling effect because most people were already reporting doing that. And then having the seat inspected is where we had another very significant increase in taking advantage of these car seat checks. So we were very excited about having positive results with an intervention that is fairly simple once you get it, because now you can drive parents to this app in any number of ways. It doesn't have to be in medical care, although that's a researchable question. Are parents more likely to take this up when it's in a medical setting, or would they be just as likely to download the app and use it if they received it at a retail outlet, for example? So that's a very quick run through of the kinds of things that we've been doing for decades, since my son is now 39, to increase the use of car safety seats in Maryland and in a low-income disadvantaged community in Baltimore. So the conclusions I think about are, obviously we still have a lot to do. Unintentional injuries are still the leading cause of death for our kids. We have lots of proven effective solutions, but they're not reaching the most vulnerable populations. This technology and partnerships can really help in medical care settings to enhance intervention work. I think that we need to understand better how we can get successful dissemination and behavior change. There's a limited amount of theoretical work being done to really understand dissemination and behavior change. And the last point, or the last 2 points, are that it can get hard to try to do all these partnerships with all the different groups who are involved, and you really staying focused on the end goal of saving lives has really been something that's helped us with our partners in the fire department and in the medical care delivery system. But I think what really has helped us most is illustrated on my last slide. 2 of the greatest virtues in life are patience and wisdom, and it really helps to have some of both. So that's what I wanted to share about car seats. So thank you very much for the invitation to be here.
Thanks, Andrea. I think we've got time for some questions. If there's anyone got any questions or comments they'd like to make? Okay, hang on, you need to use the microphone.
Thank you very much, Andrea. As always, absolutely loved that presentation. Quick question on the children in the control group. I was intrigued by those in the control group. There was quite an increase in children whose seats had been checked.
Right.
After 3 months. Do think that was simply because of the process of being involved in this trial, or?
Well, I think there's a priming, priming when you keep asking people the same questions. So they were asked if they'd gotten their car, even though they were in a fire safety condition, when they were interviewed, they were asked about their car seat behaviors. So I'm sure that had to have had some kind of effect.
Moving them along the...
Right, and that, I mean, I think that's why we really focused on the change in change comparison.
Absolutely.
Yeah, yeah. The other issue is with it being self-report. We've also been asked about that, and it is self-report, that's what we have, but the rates that we got are substantially higher than other papers that have come out on self-report. So they usually run around, for us, they usually run around 40-45% self-reported rates. So we felt pretty good about the 70%, even though we do acknowledge that as a limitation.
How did that partnership with the fire department come to be?
Oh, thanks for that question. Yeah, when we built the Children's Safety Center a long time ago, one of the products that we made available were smoke alarms, because the Baltimore City Fire Department will install smoke alarms for free, and we became their largest referral source for smoke alarms, and so then we had that sort of partnership, and we wanted to build on that, and that was fun. Yeah.
Okay, well, thank you very much. It's fantastic. It's not very often that we have the opportunity to have international guests visiting, so thank you so much, Andrea. But we have another. So Alison McPherson, actually Alison and I were actually having a conversation this week about how long we'd known each other, which is so long that we can't remember when we met, but probably at least 12 or 15 years. Alison's a professor in the School of Kinesiology and Health Science at York University, and she's done a lot of work in paediatric research, child and injury. She's got a Canadian Institutes of Health Research Chair in Child Health Services and Policy Research. So Alison's going to talk to us about evidence-based policy and transport-related injuries.
Thank you very much, Rebecca. And I have to echo Andrea and say I'm really thrilled to be here. And thank you for the invitation to come to Sydney. It's certainly a lot warmer than Toronto in Canada, where I'm from. So I want to acknowledge that this work is a large body of work that was done primarily by Dr. Liraz Friedman, who is one of my PhD students. She's now doing a postdoctoral fellowship at the University of Calgary. But none of this work would have been possible without her, and I'm sure she would have loved to come and present it herself, but I'm doing it on her behalf. So things like bicycle helmet legislation, booster seat requirements, and graduated driver's licensing have shown evidence of effectiveness in preventing pediatric injuries. And in particular, I'm going to talk about graduated driver's licensing. And if you don't know what that is, I understand you have it here in every state in Australia as well. When a learner driver starts, they have certain conditions, they have to do a certain number of hours, they have to do training courses, et cetera, et cetera. And it's consistently been shown to reduce motor vehicle crashes in youth. And there was a Cochrane systematic review that concluded that the stronger the graduated driver's licensing program was, the stronger the program, the greater the decrease in injuries in that population. So we initially did an evaluation of evidence-based pediatric injury prevention policies across Canada. So Canada, kind of like Australia, has a federal government that's responsible for the whole country, and we have 10 provinces, like your states, and then we have 3 territories. I believe you have a territory in the north as well. And so each provincial government has jurisdiction over most things related to health. So there's quite a lot of variation between provinces in terms of their enactment of evidence-based injury prevention policies. I'm not going to talk about bicycle helmet legislation. Jake's probably heaving a huge sigh of relief at that. But for example, we still have 2 provinces without any bicycle helmet legislation in Canada, even though the first laws were enacted around the same time that they were in Australia in the early 1990s. So to focus on graduated driver's licensing, it can include mandatory versus voluntary driver's education, blood alcohol content restrictions, a nighttime driving curfew, passenger restrictions, being forced to have an L and an N sign plate on the back of the car so that people know that you're a learner or a new driver, and time discounts for driver's education. So in terms of these, we think the driver's education should absolutely be mandatory. In Ontario, the province where I'm from, the blood alcohol content, even out of the GDL phase, is 0 until they're 21. Obviously, that's better than allowing them to have any alcohol. Nighttime driving curfew, there's a bit of mixed evidence about that, but there's certainly evidence that they shouldn't be driving in groups late at night. Passenger restrictions, same thing. It's all right if they're driving with their family, but there seems to be something that happens if they're driving with their friends. And the L and N sign plates, and time discounts for driver's education. And that's kind of a funny one because it does happen in the province that I'm in, that they give a time discount if you've done the driver's education. You don't have to be in the GDL phase for as long. But in fact, that's a paradoxical thing, and that we don't recommend time discounts for driver's education. So this is supposed to be busy. I don't expect you to read it, but this was a summary of all of the different types of programs in Canada. So we have bicycle helmet legislation, booster seat legislation, and here at the bottom is graduated driver's licensing. And the only thing I really wanted to point out about this is that no province had all ticks, right? None of them were consistently the best. And the things we looked at were the learner stage, intermediate stage, blood alcohol content. We also looked at cell phone restrictions because that's become a huge issue in Canada, texting and driving and talking on the phone while driving. So what we wanted to do now is to say, we were going to do an interprovincial comparison of hospitalization rates, death rates related to motor vehicle collisions, and then summarize the differences in graduated driver's licensing programs across the Canadian provinces. We didn't do any of our research in the territories. Our territories, I think, are kind of like your Northern Territory. They're sparsely populated, they're very far north, and most of the population in those territories is Indigenous. It's our Inuit people, largely, and there's just not enough of a population base. A lot of them don't have roads. They get around by ATVs or by snowmobiles in the winter. So we didn't have the numbers to do this kind of analysis in that population. Not that we don't care, it's just that we couldn't do it. So all of our health information is gathered by the Canadian Institute for Health Information, and we have a discharge abstract database. I believe our health system's kind of like yours. It's funded socially. People don't have to pay out of pocket for their healthcare services. So every single hospital discharge is captured in the discharge abstract database. We also have a vital statistics death database and provincial coroners data, and in aggregate, that's very good data. It turns out by province, it's not very good at all, but I'll talk about that in our limitations. And so we wanted to look first at broad cause, all motor vehicle transport incidents. So we looked at occupants of cars, bicycles, and pedestrians. But then we wanted to really focus in on the occupants because that's where we think the graduated driver's licensing is going to have an effect. So for the comparisons, again, we looked at those same things we talked about before. So these are our results. So on the x-axis are our provinces, and the way it's lined up, it goes from west. So BC is British Columbia, which is on the west coast of Canada. Alberta and Saskatchewan and Manitoba are what we call our prairie provinces. They tend to be very flat, quite rural. Ontario is the province in the center. It's the province where I'm from. It's the most populated province. And then we have, we don't have data from Quebec, for those of you who know Canada, for all kinds of reasons. Newfoundland, New Brunswick, Prince Edward Island, and Nova Scotia. And there, we do have those data for the territories. So that's all transport-related hospitalizations. So I think what I take away from this is, and the red line is the Canadian average. There's a lot of variability in the transport-related hospitalizations across the Canadian provinces. So then we wanted to look at certain specific provinces. And we chose Saskatchewan because typically Saskatchewan has the worst injury rates and also has the fewest evidence-based policies. So we can see in 2006, the population-based injury rate for Saskatchewan was 146 per 100,000 population, compared to the Canadian, which was 85. So that's a pretty big difference. And by the end of the period, Saskatchewan, the rate had come down by 19.5%, but is still well above the Canadian average. And this is Ontario, which started off quite low, well below the Canadian average, and remains well below the Canadian average. And they had a decrease of 31% over that same time period. So now I'm just focusing on motor vehicle occupant-related hospitalizations, and we see a similar pattern. Ontario is well below the Canadian average. BC does better in this than it does in all the other ones, but Saskatchewan still has a really relatively large burden. And so does Prince Edward Island in this one, so we chose to look at it. Although Prince Edward Island, I have to say, is a very small province, it's not very populated, so the rates aren't as stable as some of the other Canadian provinces would be. But in 2006, their rate was really quite high, almost triple the Canadian average, and they took that pretty seriously and they've brought it down to about double the Canadian average. A decrease of 64%. But again, please remember those numbers aren't terribly stable statistically. And these are the occupants in Ontario, and they had a decrease of 44%. And this is the Canadian average motor vehicle occupant-related hospitalizations only for 15 to 19-year-olds, which is the difference in this one. And we see a fairly similar picture. And then if we look at PEI, again, they had a huge decrease. And Ontario, again, a rather large decrease. So the last piece of data I'm going to show you is the population-based mortality rates. And we took the data from 2006 to 2012. And the reason we did this because some of the environments to drive in Canada are different. We can have very harsh winters, we can have icy roads, we can have very bad weather. So we didn't think it was fair just to sort of put out the hospitalization rate into our mix. We wanted to look at the death rate and we wanted to look at the change over time. So here we have the percent change, and one thing I have to note, I noticed this earlier today, this is minus 79.32. It's a big, they didn't triple. But we can see almost all the provinces had a pretty large decrease, except for Manitoba and Saskatchewan. If you move to Canada, don't move to Saskatchewan. I'm only kidding. It's a beautiful province. But, so here we can see that. And then we scored their GDL policies, as we talked about. So in order to get a score of excellent, they had to have a minimum of 12 months duration in learner's phase, no time discounts, mandatory requirements for at least 50 hours of supervised practice. None of our provinces scored excellent. And then good was a minimum of 2 of those 3, and then fair was no minimum duration and no mandatory requirements for at least 50 hours of practice. And we didn't have all of our Canadian provinces, and I understand all of your states, to have graduated driver's licensing. It's a big success story in terms of injury prevention policies. But I'd like to highlight here, Saskatchewan only ranked fair, as did Manitoba. So those are the provinces where they didn't have a big push to have a stricter graduated driver's licensing enforced. So our conclusions are that provinces that have implemented a rigorous graduated driver's licensing programs have also seen a decrease. And the 3 main criteria that each province should employ, we believe, at the learner phase are the ones we've talked about, and particularly this elimination of time discounts for drivers who attend education programs. So this is the first study to compare transport-related injuries among children and youth across Canadian provinces in terms of hospitalization and the enactment of policies. Nobody's brought that together yet. And we hope that this data may influence prevention through the harmonization of these best practice policies. However, factors other than policies, legislation, things like awareness campaigns, changes to the built environment, changes in health service utilization. We don't know if maybe the threshold for admission to hospitals has changed. When we talk to pediatricians about this, they say it has. And some of our numbers were a little bit unstable, and the death data was for all ages because we weren't allowed to split it up into smaller chunks. So it's hard, especially with the death data, to say it's associated because that was 0 to 19. However, I mean, we still believe that there's something here, and we're really going to work with the provinces actively in the next phase to develop interactive report cards that they can use to harmonize their policies with the best practice. And we work with lots and lots of people on this, and so I'd like to thank them. Thanks.
Thank you very much. It does put a bit of a spotlight as well, and you think realise how strong our graduated driver licensing programs are in Australia with New South Wales, 120 hours of mandatory supervised driving practice. Okay, now yeah, it's great. Anyone got any questions for Alison? Yep, take that.
It's really not that important. I'll talk loudly. Just a very simple question. Was there any variation in the starting age for drivers across the different provinces, or they all start at the same age?
They all do. Everybody starts at 16,
Yep.
Except Alberta, which has a very big farming community. So they can start to drive certain farm machinery like tractors at 14.
Okay.
But otherwise it's the same everywhere else.
We have a sort of a conflict in Australia where New South Wales and Victoria have different starting ages and things like that, and that might have different effects flowing through the data going through the system. So, thank you.
Just to comment on that, my friends who are, and maybe you know more about this, who are neuroscientists say they should not start to drive before they're 16, that their brains aren't developmentally ready.
Well, according to my recent experience, I don't think they should do it at 16 either. This is speaking as someone who ended up on the nature strip with all four wheels of the car on the nature strip, the handbrake applied just at the edge of a cliff with my 16-year-old daughter. And I'm sure it was her, not me. Okay, thank you very much, Alison. Okay, now I am absolutely delighted to get Bernard up here. Bernard, as you all know, is the Executive Director for the Centre of Road Safety and Transport for New South Wales, and he's been there since 2015, but he has actually been responsible for the development and delivery of the New South Wales Road Safety Strategy for far longer than that. So welcome, Bernard.
Thanks very much. It's great to be here. So I'm here to talk about our journey on serious injuries and the linkage project that we have, and where we've come to today, which is a fantastic place for us because for many years we've been in a situation where we haven't been able to accurately assess the trauma associated with serious injuries in New South Wales. When we start out looking at this, essentially the New South Wales Road Safety Strategy and set the parameters for us to actually drive forward with getting this data settled in New South Wales. Until 1997, New South Wales relied on police paper reports about collating serious injury statistics, which were essentially their view of whether somebody was seriously injured or not, and writing it down. Not a very reliable system, and consequence of a change to the computerised operational policing system back in 1997, essentially that data disappeared, and we've been for a period of almost 20 years or 15 without that information to be able to make effective decisions. Several attempts were made over subsequent years to publish health data. One-offs have been conducted, but since 2012, where we commissioned a study to identify serious injuries, data linkage processes with our academic colleagues. That success of that in 2013 led to us refining that process and then working with our partners in making that happen. So TARS was instrumental in that study originally in giving us that framework together to make this happen in New South Wales. So we commenced our major data linkage study in 2013. Essentially, we approached health to seek their support and regular data linkage. They've been very positive and helpful in this process. And I know on the National Task Force for Road Safety of all the other jurisdictions in Australia, they certainly haven't had the level of cooperation and support that we had in New South Wales, and they've struggled without that commitment and support of their health agency. We needed approval for our project from data custodians and ethics committees. So we had approval from the New South Wales Population and Health Services Research and Ethics Committee in December 2013, and then the Aboriginal Health and Medical Research Council Ethics Committee in January 2014, and ACT Health Services and Ethics Committee in November of 2013. Really fundamental processes for ensuring the support and the robustness of the system that underpins us now today, being able to publish this data on our website, publicly available in detail for people to actually manipulate and have a look at what the impacts are of road trauma in terms of serious injuries. So our road safety information supports a safe systems approach. And certainly the whole capability framework that we've been developing over the last 5 years has been critical to our success in designing our response to the road trauma in New South Wales. And the injury severity information is only one element of that. So we, in terms of health and mortality information and the ACT's identification of injury severity for Aboriginality, we're the only jurisdiction that is publishing data on our website about the impact of road trauma on our Indigenous community in Australia. And that's been a fantastic effort and, as you can imagine, quite a sensitive ethics issue to work through as well in terms of the low numbers, but being able to give that information to the community and work then with our Aboriginal community and solutions around that road trauma problem. We're the only organisation in the jurisdictions at the moment who has the data about the safety attributes of the vehicles on our road registered in New South Wales. And so we're able to match against our registrations in New South Wales to be able to confidently say that 41% of our vehicles in Sydney are 5-star rated under the ANCAP rating system, but only 34% of our vehicles in our regional areas are 5-star rated for passenger vehicles. And so we get a much clearer picture of the system that we're working with in terms of that safe systems approach to tackling road safety in our jurisdiction. So let's move along. So we are working under a framework which is really guided by the national data sets around classification of killed and seriously injured, moderate injury and minor injury. We have a national road safety strategy that says serious injury is an admission to hospital and killed as a person who dies within 30 days of the injuries received from a road traffic crash. Clearly our matched data with police report gives us a lot more detail in terms of the geospatial attributes and what the incident occurred on the road and the contributing factors to that. But the unmatched data is not insignificant. The hospital data and reference information around the individual themselves and the vehicle counterpart and the impact of the crash is significant information that demographic information has been really valuable in terms of us being able to understand, as you'll see, the quantum of that impact on our community. Wouldn't have happened. So we are actually at a point now where we're also working with ambulance data, so that'll become part of a linkage process in 2018. Work cover claims is part of that process that we're working on at the moment as well. And more detailed research into the unmatched serious injuries. In particular, we're talking to our cycling colleagues from the cycling representative organisations today about some detailed work on cycling. So we've implemented this 4-way linkage of our crash data, health admissions, emergency department data, our state insurance regulatory authority claims data, our lifetime care data. And of course, none of this happens if you don't have the collaboration and cooperation of those agencies working with us in a really collaborative way. And I think the last 2 presentations are clear indications that that's how you get success in this area, is by having that collaborative approach across not just government agencies, but also the research institutions. So let's get to the crux of it. So now we have a fairly clear picture around the, whilst we have a matching of the police information, which we've been working on in terms of our response to trauma in New South Wales, you can see here that clearly the unmatched data, which is the health admission data without a matched police report. When you get to pedal cyclists, only 18% of our data being matched. All of a sudden, we've gone from a bit over 300 incidents where we're assessing the trauma on our roads associated with bicycle crashes, to then going to additional 82%, which we weren't able to identify. And that's a wealth of knowledge and information that's informing, again, the policies around how we deal with that trauma on our roads. Around 1,900 last year, incidents where bicycle riders were admitted to hospital. And having it live on our website, and one flight anecdote, if I can go off to the side, and I was standing with my minister a couple of weeks ago where an upper house member of parliament was saying, we should just let adults choose whether they wear bicycle helmets in New South Wales. Really? And so so what happens is that we were able to then present the facts. And the facts are, for bicycle riders in New South Wales, there were 411 who their primary injury last year was a head injury, a head trauma. And so the reality is we've been very successful. Only 5 fatalities, the lowest on record last year from bicycle riders. Tragically, 5 people lost their lives. But the reality is that we're actually protecting people through helmets, and the evidence that we now have in this data is giving us clear indication of the trauma reduction that those measures are actually having in our community. So really critically important. So you can see here, for example, the motorcyclists, only 45% of the serious injuries are matched to police reports. And so, one of the factors there is a single run-off road crash where a motorcycle rider, may have been transported to hospital by an ambulance, but in many occasions may be transported by somebody else, where there's no matched police report. And so that information is now available to us. The information that in that unmatched data, almost 400 of those motorcycle rider crashes resulted in somebody having a maximum or high injury classification. So they're not all minor injuries that are being in the unmatched data. There's quite a significant number of quite high threat to life or maximum injuries. So that information has really, I think, provided us a totally new perspective on serious injuries in New South Wales. So if we go to the road user, sorry, I'll just flick to the next slide. So if we have a look at the total numbers here in terms of the matched, unmatched, you can see here that 12,372. There's been a slight increase in this last 12 months, up to 2016. We're now publishing this data live, and so on a quarterly basis, I think the last data report was March of this year, so it's 6 months in arrears, published on a quarterly basis. And you can see a convergence here of the data associated with the matched and unmatched, and essentially police reporting of an attendance at crashes. Those protocols have changed in New South Wales over the last couple of years, and so you can see that the matched has actually dropped slightly, but as the unmatched is still being captured as part of the system in terms of admissions to hospital. So our hypothesis here is that we're not actually missing these events now that we have a matched data set with New South Wales hospital admissions. So how serious are the injuries? Well, whilst the data linkage results align with the National Serious Injury Definition, we've introduced 2 metrics to measure the severity of serious injuries. And they are the high threat to life, a 2-point scale based on our ISIS scores, and the injury category, which is a 4-point scale based on those ISIS scores, and I referred to them a little earlier. In addition to these, crash link records linked to our Insurance Regulatory Authority CTP claimant on 3rd measure has been incorporated into the linked data set. So that maximum abbreviated injury score, that MACE 6-point scale, has been incorporated. So what's the high threat to life? It's a measure of the severity based on the likelihood of a patient will survive a particular injury, and a yes high threat to life translates to an ISIS score of 0.941. So the reality here, that's a person that has at most a survival probability of 94.1%. And you can see a significant number, that 3,471 last year, were in that high threat to life category. Also, this is another part of that dialogue that we have with our cycling colleagues today. A significant proportion of our cycling crashes where they have a head trauma have that high threat to life rating as well. So for all age groups, high threat to life for the matched serious injuries is higher in terms of the police attendance, which you would expect. But there's still a significant proportion in that unmatched data of hospitalisations that are high threat to life category. And another interesting aspect of this is that, again, it's increasing with the age categories as well. And I think there had been discussions, I think, before we got this data around, more potential of a U-curve in this data rather than a projection which actually sees the threat to life increasing as the age categories go up. Naturally, with the older age group, you'd expect to be seeing that as well. So the injury profile, so the data also relates to this is data for all road users. Principal injury type, the body regions derived from the principal diagnostic code for the, and you can see here that in New South Wales, out of all of our serious injury, the head injury was the primary injury that's recorded in the data. The most common type of sustained serious by the road victim, followed by thorax and then neck and knee and lower leg. When we then have a look at the more detailed of the particular road users, so motorcyclists, we're able to then see the difference that we have in the data around the injuries, and head injuries dropped to 10% here, and clearly motorcycle helmet usage has a major impact on the injuries. And we see the most common type of injury sustained by seriously injured motorcyclists is the knee, lower leg, followed by shoulder and upper arm at 14%, and elbow and forearm. And those respective proportions are at 62%, 72% and 80% of the elbow and forearm injuries in New South Wales data for those motorcyclists. Then we look at the road user groups, and you can see here the driver as well being the main group who are actually sustaining serious injuries in our crashes. Again, we compared with 2015, drivers and motorcyclists were the only road user groups to have experienced increases in hospitalisations in 2016. And I think as well, we're quite surprised when you look at the data for our fatalities around pedestrian fatalities, which have increased significantly. And when we compare them with cyclist fatalities, they rate significantly higher as a road user type. But pedestrians here in our serious injuries are actually the lowest road user group in terms of our serious injuries outcomes, and have actually been in decline over a number of years as well in terms of the numbers. So there's significant difference in the category of injury and the type of crash type that's actually being experienced that's leading some of these outcomes. So we go to the age group categories, and you can see here that those middle age groups of 26 to 39, 40 to 59 and 60 plus have experienced increases in hospitalisations. Clearly the 40 to 59 age cohort are the significant bulk of those serious injuries. And of interest here is that trend that we see in the 0 to 16, significantly reduced serious injuries for that cohort when we compare those to the 60 plus, which has had a significant growth in the serious injuries since 2005. If we then go to those matched serious injuries associated with speed limits, and over half of our people seriously injured are involved in crashes on roads signposted in 50 and 60 kilometres an hour. And over recent years, the numbers of serious injuries have fallen in the speed zones. but you can see the 40Ks is quite low as well, and we've just finished an evaluation of our 40K speed zones, which has seen over the last decade a 38% reduction in casualty crashes in those 40K speed zones. Similarly, 1 in 5, 19% occurred on high-speed roads at 100 kilometres. Over the last 2 years, there's been a 14% reduction in those as well. In terms of the matched police reports for those contributing factors to those crashes, there's a very similar structure to the fatalities in terms of speed, fatigue, alcohol and restraint non-use. But the reality is that 23% of speed-related fatalities in that 5 years is 7,610 admissions to hospital. So a significant load of trauma associated with that. In our fatality data, we see a much stronger percentage of around 40 to 42% speed-related. We'd assess this as being part of the reporting process that police have in relation to the way in which they gather the contributing factors for serious injury crashes versus those fatality crashes, which have a much more robust investigative process wrapped around them. So nevertheless, speed's implicated in, 1 in 4 serious injuries and fatigue, 1 in 8, and consistent with the change that we've seen in fatalities, the fatigue-related have stepped up above alcohol-related in the same way in serious injury data. So again, all of this information and data is available on our public website for people to interrogate, and thanks very much for listening.
Wow, thank you so much. It is fantastic, that data. It really is. Every time I hear Bernard speak about it, I'm just amazed, and it really does drive. Welcome to, I know, and we all know it's the team behind you as well, Bernard. It's fantastic to see. For me particularly, the Aboriginal and Torres Strait Islander data's great, but just the way we're going to be able to actually look at interventions as well over time and the effectiveness, it really is important.
There we are. Thank you, Bernard. You showed us the data for speed and fatigue and alcohol and so on. Are you intending to include extra categories, so for drug driving, for distracted driving, or just for people who do illegal traffic manoeuvres like crossing unbroken lines and so on?
Yeah, so again, that's going to be driven by the data collected by police, but we have that information. We have that data available in our matched data set. So yes, we are able to interrogate based on all of those codes that police actually load into our system on the matched data.
Great, thanks so much. Okay, now we're moving on to some of our researchers. Associate Professor Lisa Key, she's a Deputy Director of the Injury Division here. She's been doing work in older drivers. She's got a program of work around ageing and injury, and she's going to talk to us about some of that work. Thank you, Lisa.
Thank you very much. Okay, and it's a pleasure to come on from some great presentations, and one thing I won't be doing today is summarising any of the safety data. I think this room's quite familiar that there's some trends in, as Bernard said, growth in crash involvement for older road users, but also we recognise that they have greater vulnerability to injury as well. But today what I want to talk about is the challenge of balancing safety and mobility in this age group. There's actually a vast amount of literature which has really mapped the changes that occur with age to vision or cognition or other aspects of function that can relate to our driving ability and therefore can have impact on our crash risk. And we have to keep in mind, though, that driving is a very core function in our everyday lives, and the pictures here on the screen already inspire a bit of nostalgia in what we've seen over the years with cars changing. But it's a really strong part of our identity, and we've certainly built our cities and to rely on on private motor vehicle transport. And we know that older people do tend to want to drive until they are no longer alive. They don't plan for retirement from driving and are not typically using alternatives if they have a car that their preferred mode of transport. So we embarked on a program of research, having been working in this space for a while, looking at some of those changes with ageing. And we investigated a program which we called the Behind the Wheel program. It's actually based on a program developed in the US, which is relying on an educational approach to try and encourage people to drive as safely as possible for as long as possible. And we tried to follow the best practice principles that Andrea so elegantly described earlier, in that we had an individualised program that was tailored to the driver's level of engagement with the self-regulatory process. So we went through a process of working out what stage people were at before we went into our program manual and pulled out the relevant parts of the curriculum. So we had 2 individual sessions, 1 month apart. And the example on this slide shows that, you know, for example, you might want to engage with people about the level of vision, and you can lose a bit of contrast sensitivity, perhaps with changes like cataract. Then this relates to driving, because we get some very unusual driving environments and some challenging, particularly with glare. So what do people do with this information? They could build skills to do with where they drive, which intersections, is it a setting sun, times of day, and in fact we hoped that people would build their own plans out of this program, so a safe mobility plan or retirement from driving plan. One other aspect of this program, which was quite, I can't really go into all the details, was that we actually really tried to link people in with transport options. So we took along a pack that was for each jurisdiction that we worked in, that had all of the community transport options, public transport options, the courtesy buses that they could take advantage of, and took an inventory of their transport needs and then linked them in and showed them how to do this stuff. We didn't get to take them out and teach them actually how to do it, but we gave them the information, and part of their plans was often about, many cases involved using some of these alternative forms of transport. So we got some funding to evaluate this program, and we did a randomised controlled trial, and it took us about 3 years to complete the trial, which was involving 380 drivers who were resident in the suburban outskirts of Sydney's, in the Hills District and the Hornsby-Ku-ring-gai Shires, for those who know the city. We instrumented all the cars with an in-vehicle monitoring device, and we also did a comprehensive battery of tests to get to know our participants, and they were in the study for 12 months. So half the people got that program in the 2 sessions, and the other half continued as usual. One of the tests that we did use was this, there's many tests of driving related function, in-office tests of ability, and this was called the Drive Safe Assessment. And you can see that the scores on this test were quite varied. People got quite low scores all the way up to quite high scores, and we pre-specified that we wanted to have a subgroup based on the level of function, because we know age does not equal function. And so there was a published cut point, and we kept this in mind for our later analyses, that we wanted to look at that subgroup in particular. Okay, so just to show you what our cohort was like, they were on average 80 years of age. We only recruited people 75 years and older. And you can see some different descriptions here. As typical of this age group, quite a few comorbidities and medications. And we did a few different tests that I don't have time to go into, but just to show that there's quite a distribution in scores. So there's quite varied abilities and level of vision, for example. And that some of those tests are showed up the top. And we actually had lots of different outcomes in this research project, and I'm in a good position now to present this project because we've published and analysed all of these different outcomes. And I'm going to try and give you a snapshot of these results as efficiently as I can, just to give you an idea that we did try and look at safety as well as mobility. So we had different outcomes that we were looking at. Our primary outcomes are listed there, and the first ones I'll talk about is our crash rates, which was a secondary outcome. It was only self-reported, but rapid deceleration events were our major outcome as far as safety. So once we checked the quality of the data and instrumented as many vehicles as we could, we had 351 participants with a median of a year of data, and they travelled about 5,500 kilometres during that year. So we did some analyses which looked both at the self-reported crashes. You can see we had 14 in our intervention group and 19 in the control, but definitely no power to investigate that difference, very small numbers there. But we did have sufficient power to investigate those rapid braking events, and you can see that it was slightly lower rate in the intervention group, but not statistically significant. So it's about, the incident rate ratio is 0.85. But remember I talked about that subgroup, and we looked at our subgroup, and I checked the protocol paper this morning, and we actually hypothesised that the low functioning group would have the biggest difference, because we thought we'll really make a difference there because we can change that. But that's not what we found. We did find a differential, but the people that we could make the difference in that incident rate ratio being different was in the people with the good scores. So maybe they're a teachable group, they're the the younger old, if you like, and they were able to make changes to their driving to make themselves a bit safer. So that was encouraging. And if we put it on a forest plot, just to show here, and for those who are familiar with this format, if things are overlapping that line right down the middle there, that means there's no difference between the intervention and control, and on the left, favouring the intervention. You can see the only group that we had a benefit in, no difference between men or women or actual age, it was the people who had the better scores on that test. So quite an interesting result. Now, when we looked at, we really wanted to change how much people drove, how many kilometres they were on the road, because that's obviously going to change your exposure and your likelihood of being crash involved. And it was really hard to shift driving kilometres. So on average, about a 5-kilometre difference between the intervention and control. Some other things listed on this thing, some of our other outcomes, very similar level of participation. They were quite an active group overall. Andrew would be familiar with the behaviour profile, and that was encouraging that we did change, we educated them, we got them to engage in the process of self-regulation, but we didn't actually see it realised in kilometres on the road. And then when we put this and explore it a bit more in our subgroups that we pre-specified, you can see that the men and women and by age is not much different, but we start to see some interesting trends again, depending on their level of function. And none of this is statistically significant, but it's nice to ponder. And if anything, we're getting kind of a U-shaped effect there. But really hard to change the mileage. These people all stayed drivers and they really kept driving the same amount of distance. But this is a very interesting result. We included a geriatric depression scale, and what this shows is that if you get 2 or more responses on that scale, then you have got depressive symptoms and you're at risk of developing depression. And inadvertently, we did increase the number of people who had depressive symptoms in our intervention. So that was a disappointing result, I guess, but also a useful result, because we have to keep in mind that if we take out a strong message to people, then we can have some negative consequences. And that was actually evident in the group with the low function. So they're the people that got the more severe message, if you like. So very interesting, but a real word of caution. We looked at how much people use other forms of transport, and this was triangulating self-reported data as well as the in-vehicle monitoring data, and that showed that people are overwhelmingly driving still at the end of the study, no matter which program, whether they got a program or not. So it's nearly 90%. We got slight lift, but nothing significant in people using a bit more public transport. But this, I just put some data here from Australia, which is a big national survey from the Council of the Aged, and that shows that really 85 plus people trips are driving trips. And this graph is nice because it shows that we're more reliant on driving as we get further out of town. So just to show that things are a bit similar there. One little hint of something might be going on in our intervention when we go and give people information about what's out there. We only had 11 people who retired from driving, but out of those people who retired, only our intervention group reported using some transport. So the retired drivers, there was only 4 of them who were in the control. They didn't report any transport use. So if we could do the study in all retired drivers, maybe that would be an interesting thing to do. So in summary, we found that it was difficult to change driving exposure, but we may have had some safety benefits in the higher functioning younger old. But we do have some word of caution about taking this out and not providing adequate support. And I'm happy to say that we're doing a 4-year follow-up at the moment where things are looking very interesting, and we'll certainly look at a few more of the retired drivers, though they had the program some years ago. And I'd hate to finish saying that we've finished all this research and there's nothing more to do, because there is a lot more to do, and I think this is echoed in other statements from consensus statements about this really important research agenda, which is about balancing safety and mobility and looking after people as they transition. And there's a few hints here, and I think one of the most exciting things is we didn't get the chance to look at the new forms of transport that are out there, like Uber and things like that are out and may really make a difference to older people's mobility as they try and get less reliant on cars. So thanks very much, and I think I'll pass back to Rebecca.
Fantastic, Lisa. I mean, it was a fantastic, really well-conducted randomised controlled trial, and I mean, I guess shows us why we need to do trials as well. Really well done. I'm going to just hold over questions till the end in the interest of time. You will notice we're not sticking to the timing in the program, so if any of you want to leave at 4:45, you're going to miss out on the last few speakers, so I'm sorry about that. I'm going to hand over now to Julie Brown. She's a researcher at Neura, and very well known to most of you, and she's going to talk about research to improve protective equipment performance for vulnerable road users.
Okay, thanks, Rebecca. and it is nice to be here. Okay, so I thought I'd just quickly start with a quick overview of the current road safety related research that we're doing at NEURA and at the Transurban Road Safety Research Centre at NEURA, the work that we've done in the recent past and going forward. So over the years we have done a lot of work in child passenger protection and looking at improved protection for rear seat occupants as well as older driver and occupant safety and motorcycle safety and rider protection. But today, in the interest of time, I'll just stick to telling you a little bit about the work that we're doing in child passenger protection. And so for optimal crash protection from existing occupant protection systems, we really are relying on optimum equipment performance and optimum use by the users. And over the last few decades, we really have come a long way with occupant protection technologies, and we've seen really significant improvements in optimal crash protection under optimal use conditions. But what I'd really, I suppose, like to talk about today is the challenges that we face in achieving optimal crash protection due to user behaviour and the components of some of our research programs that are aimed at addressing these, and also the interaction between user behaviour and the design of restraint systems. So I'm not a behavioural scientist, and my knowledge of behavioural theory is really quite limited to just knowing that there are a lot of theories out there and a lot of behavioural models out there. But a few years ago I did come across this integrated model of behaviour that had attempted to put a few of these together. And really what this model says is that a person will, if a person has the intention to perform a behaviour, the person will perform that behaviour if they have the skills to perform that behaviour, and there's no physical constraints or environmental constraints preventing that behaviour. And I think that it seems to me anyway that a lot of the behavioural approaches when it comes to restraint use in the past have really focused on intention and the determinants of intention. And of course there's exceptions to that with the work that Andrea does, and I think our buckle up safety intervention went wider than intention as well. But we have simply focusing on intention has been successful. You know, if we think about the success of legislation and enforcement, which I think acts through this pathway, we have seen good successes with increased use of restraints. More than 90% of children use restraints, and we're seeing more and more children moving into the right sorts of restraints for their age following the new legislation. But we continue to have problems with correct use, and this is a long-standing and widespread problem. So our recent estimates, we have nearly something like 1 in 2 children having at least one error in use whenever they're travelling in a car. And so our thinking has been is that one of the reasons for this may be that we've forgotten to address these skills and environmental constraint issues. So, because to use a restraint correctly, they need to have the skills to use it correctly, they need to know how to use it correctly, and there needs to be no physical barriers or nothing stopping them from being able to use it correctly. And so the work that I'm talking about today is really about addressing these issues. And we're doing that through 2 parallel streams of work. So the first one is, in the first one, we're looking at the informative materials that are supplied with restraints, and in the second stream, we're looking at the actual design of restraints. So by informative materials, what I'm talking about is the instruction booklets and labels and information on the packaging. And parents really do identify these materials as primary sources of information on how to use child restraints. And we've chosen to look at these because despite the fact that 50% of restraints have got errors, In a recent survey of just over 400 parents, 90% of them told us that they had read the instructions, and 75% told us that they found the instructions really easy to use. But we know that they're getting them wrong, and we also know that their instructions are currently written at much too high comprehension level. And this is particularly a problem for those with low English literacy. And we've also really quite recently demonstrated in the lab significant correlations between poor comprehension scores of instructions and the types of errors that we're seeing in the real world. And another really important piece of background is that design standards like the Australian standard and all the child restraint standards around the world do actually include quite a lot of requirements about what sort of information needs to be supplied with child restraints, and in some cases how that information should be formatted, for example. But the reality is that all of these requirements are basically based on expert opinion only. And we know in other areas of health communication, for example, that it's really important that consumers are involved in the development of informative materials. But when it comes to child restraint product information, consumers have never previously really been involved in the development of that information. So we've borrowed from this health literacy approach that's used in developing health information such as consumer information supplied with medicines, both here in Australia and also elsewhere in the world. And this approach was developed by an Australian actually named David Slets, based on this model of information design, which includes this iterative step of prototype development and conversation and refinement. So for the child restraint information, the process we've taken was to collate existing evidence on human factors and instructional design, as well as conduct functional task analysis on the correct use of child restraints. And then importantly, we used qualitative research methods to actually get feedback from parents and users of child restraints so that we could develop what we would call our best evidence prototypes. And then we use this iterative consumer testing process to refine and ensure that the materials were being well comprehended and did result in correct use by the users. And so our prototype materials that we've developed, and I should say that this work is largely forms a large part of Alex Hall's PhD, last 3 years' work of Alex Hall's PhD. So she's developed these prototypes, and based on our feedback from the consumers, we've developed this A3 information sheet that includes QR codes that link to online videos, as well as a swing tag-like arrangement that sits on the restraint and prompts for the most common types of errors that we see. And Alex is just in the final stages of doing a laboratory-based controlled trial to check how these are working. And we've got a sneak peek at some of the early results, and you can see that the intervention, we've got substantially increased comprehension in the intervention groups, as well as, importantly, we've seen reductions by a factor of 2 in the number of errors in people that are supplied with this intervention material. And also, really importantly, we've seen substantial reductions in the severity of errors that are continuing to occur. So, but of course, comprehending the materials and demonstrating the correct use in the lab is one thing. And so now what we're doing is commencing quite a big NH&MRC funded RCT to see if this holds true in the field, and also 6 months after exposure. So in this trial, where it's a cluster randomised controlled trial, and we're using stores as the clusters, and so parents will be allocated to the control or the intervention depending on what store they go to, and they'll receive the material with the restraint that they purchase. And then 6 months later, we're following them up, and we're putting a video in their car for 24 hours and having a restraint fitter check the installation to get our outcome measures. So the other part of the work is looking at restraint design. And so we know that incorrect use occurs through two primary mechanisms, either the way that the restraint's installed in the car or the way that the child is secured within the restraint. And for the latter, this can occur when the adult or some other parent installs the restraint, but it can also, these other types of errors can also be introduced by the child themselves sometime throughout the journey. So in this part of the work, we're looking at the interaction between the parent and the interaction between the child and the restraint. And where we're up to in this part of the work, for the interactions between the child and the restraint, we've developed novel methods for quantifying comfort of children in cars and in car seats. And we've established for the first time a link between the comfort experienced by the child in their car seat and errors in use, as well as variations in comfort and variations in errors in use by different types of restraint types. So we're currently in the process of validating these observations in the real world using naturalistic methods. And then the next part of this work that we hope to start next year involves observation of children in their restraints in their own vehicles in a population representative sample that will not only allow us to update population estimates of appropriate and correct use of child restraints, but it will also allow us to examine the influence of specific types of design and specific design features with specific types of errors. And so then the final part of that work, we plan to conduct another randomised control trial out in the field to hopefully demonstrate the benefit in error reductions that we can see if we do use optimally designed restraints for positive interactions between the children and the child and the restraints. And of course, there's a large group of people working on these, and some of them are here today, Lisa, Jake, and my guys as well. That's all I'll tell you. That's all I'm going to tell you about today.
Well, I mean, all I can really say to that is, wow, that's fantastic. What a great body of work. And it's just the rigour in it is just fantastic. It's really very impressive, Julie, and I'm sure people will have questions for you afterwards.
Sorry, that's my 1,000 other slides.
Oh, okay. I'll just flick through the ones that she was going to talk about. Julie, heavens above. Okay, if you want to see the rest of those slides, come back later. Okay, now we're moving on to another centre, University of New South Wales. So this is the Research Centre for Integrated Transport Innovation, and we're now going to hear from Associate Professor Vinayak Dixon, and he's the Director of the Travel Choice Simulation Laboratory at the School of Civil and Environmental Engineering.
Thank you, Rebecca. I'm going to be talking about risk in autonomous vehicles, and which is kind of goes against some of the conventional discussion that's been happening around autonomous vehicles as being as providing the idealistic future of safety and productivity, and trying to understand what is the human factors aspect of it around the interaction of risk attitudes and risk perception of individuals, and how does that actually influence risk in autonomous vehicles. I'm the director of Trax Lab, and I'm the deputy director of RCity, and also an academic director at IAG. So I've been seconded in there looking at insurance, and that'll provide some understanding as to why some of the modeling has been done in a certain way, and how we define risk attitudes and risk perception. So, I mean, this has predominantly been one of the, whenever I talk about autonomous vehicles, it captures the imagination, and it captures the imagination associated with how it's going to improve efficiency, and there's been huge rhetorics, I would not call it rhetorics, but claims around how it's going to improve safety. So what we did was we actually looked at data from California, and there has been extensive trials that have been happening in California over the last 3-4 years. And what we did was, in California, what any vehicle manufacturer who's required to carry out trials is it has to release all the data related to disengagements, crashes, and the crashes, it's amazing, the crashes with autonomous vehicles are reported much quicker than other vehicles, so they're reported within 24 hours. So some of the fascinating things that kind of emerges, at least this is based on last year's data, is I don't think we are there as yet in terms of the ability of the system to be safe. So if you can see, there are huge amounts, like almost 60% system failures. And what are defined as system failures are failures which arise from radar sensors, failures from sensors to recognize its environment, or failure in the logic of the autonomous vehicle system. So the action of the autonomous vehicle is not in line with what it's supposed to do. So we further delved into it, and we started kind of looking at what are the metrics we can start playing around with, or to understand whether there's a exposure. So what we do find is that there is something called an autonomous vehicle mile exposure. So if you look at the number of autonomous vehicle miles traveled by a vehicle and correlate and divide that by the crash rates, you find a relationship there. Even though you see a small leveling off, it actually has been increasing over the last few months as well. So what you do find is that there's an autonomous vehicle mile exposure rate. And in fact, currently, it's higher than normal vehicles. And you can actually see that though the autonomous vehicles have not predominantly been at fault, a lot of them have been because other vehicles have hit them. And since we are only talking about California, there have been no fatalities in the autonomous vehicle crashes there. We could also start picking up on a few other things around trust. So the way we define trust in autonomous vehicles is every time the driver actually goes for the wheel and manually disengages the vehicle. So what we again find, and it's very intuitive, but you can actually see that the number of manual disengagements that happen is highly correlated with the autonomous disengagement. So when the vehicle disengages by itself and the driver has to take control. And in fact, you can actually start creating metrics where the slope of this line is identified as the trust. So those were the three main, I think, three main messages that came across from that data. And you can still see that the trend exists with the exposure rates of autonomous vehicles, as well as trust with autonomous vehicles. The other thing we found was that the perception reaction time of individuals to take over the vehicle in case of a risk was around 0.83 seconds, which is very similar to what we observe. In fact, a fair bit lower, a little bit lower than normal, but that's because all drivers are trained drivers in that scenario. So what we did was, motivated by this data, we took to our driving simulator. So we took to our driving simulator, and what we did was, hopefully I can switch on the video. So what we did was, we conducted a study with around 70 participants with a whole range of age groups. And the question we asked was, what are the impacts and how do people interact? How do people interact with autonomous vehicles that would tell us about the implications on safety, acceptability, and productivity in AVs. So apart from the safety aspect of AVs, there has been this, again, claim that people would be able to work more and get more stuff done. So the way I'm actually a behavioral and experimental economist, so a lot of my experiments are based on incentive compatible methods. So the way we identify risk attitudes are based on lottery choices. So we give them a series of lotteries, and we ask them to make choices around lotteries. So you can actually, from the curvature of the utility function and the way they actually choose between lotteries, you can identify what is their level of risk aversion, or are they risk seeking. We also induced a task for getting people to work. So the idea was actually putting a shape matching task. So we had a tablet where we had given people a shape matching task. So if it's a circle, they were supposed to say it's a circle. And for every correct answer, they would get 5 cents or 10 cents. So we had controlled for that as well. So they were different. And in a given driving scenario, people would end up doing 100, 200 of them. So they could receive a fair bit of money out of that thing. So now, the idea is that you can only be working on this when you are not driving. So you have the option of actually putting on the autonomous vehicle, switching on the autonomous vehicle and working, and then you can see how quickly does a person actually switch on the vehicle and how long do they allow it to go. But then we also had this particular treatment where we associated a probability of disengagement. So what we told individuals was that, look, there are different probabilities based on our current understanding. There's a risk that the vehicle is going to disengage automatically. Now, if you are not in control, you could veer off and crash and not kill yourself, but lose all your money. So the way we, again, induced incentive compatibility was the fact that we had given them a substantial endowment. So they had money as well, over and above which they could earn money from this task. And if they crash, they lose all their money. So now it was a choice around whether I should switch on the autonomous vehicle with a certain risk. So there was a 10%, 30% risk. So these were the results. The first thing what we found was risk attitudes. So people who are more risk averse have lower reaction times. So they tend to be risk averse individuals. When I talk about risk averse in lotteries. So people who are risk averse, betting on horses, betting on lotteries, they tend to have lower reaction time. And the idea is that they tend to be more aware around their surroundings. And we find that actually that translates to the amount of work they do as well. So they tend to be less productive in, it's not, actually age kind of shows up in that as well. So they tend to be less productive in the autonomous vehicle. And in fact, older individuals are, and you can see that we had a large range in terms of our age group. So we had all the way from 20 to around 65. And we found that older individuals are generally more risk averse, but also then tend to be less productive. So they tend to are more attentive on the road and attentive on what the vehicle is doing. The other thing what we found was there was a correlation between perception and risk aversion. So what we found was that people who tend to perceive higher risk of AVs were also individuals who are highly risk averse. So and the way we need to be, let me try to define what I mean by risk aversion versus risk perception. So what risk perception, I think it's important to make that distinction. Risk perception is the perception of the risk. So given an objective probability of a crash happening, say 10%, 20%, 30%, people might underestimate that risk in their head, that probability or that likelihood, or overestimate that. That's risk perception. And risk attitudes are given those probabilities. How would I choose something which is risky or not? So that was an interesting finding where risk-averse people also tend to have perceive higher risk with AVs. And what we also, pardon me? Oh, sorry. The last finding we found with this was that risk-averse drivers also took longer to engage the autonomous vehicles. So from an economic standpoint, that's as a person who works on economic aspects of evaluating risk aversion provides the way of, this method of evaluating risk attitudes, risk aversion provides an economic meaning. It provides us with a way of actually providing a value around risk attitudes, risk perception, and then doing cost-benefit analysis on top of that, or putting a price on insurance. the last one, it is kind of veering a little bit away from the core topic of safety, but autonomous vehicles also bring about an existential risk to toll roads, actually. So the idea was, what we wanted to study was looking at people's value of time, and would that actually change? And what we were intending to study was not just would the value of time shift. What we define as value of time is how much people are willing to pay for saving a certain amount of time. And if you're in an autonomous vehicle, you might be doing other stuff, so you really don't care. You're stuck in congestion, right? So you might not pay $30 or $10, $30 in Sydney, $10 elsewhere. So currently, most of the ways to elicit value of time, willingness to pay, has predominantly been based on surveys, and surveys have issues with hypothetical bias because people might not be in the right mood to answer the question correctly, or a whole bunch of other issues. So what we looked at was, we gave a stated preference survey to individuals, and then what we did was around autonomous vehicles and normal vehicles, and then what we did was we gave them experience in a driving simulator, and then asked the question, gave exactly the same questionnaire. And we found that our estimates of willingness to pay, after we give people an experience of what an autonomous vehicle would look like in a driving simulator, goes down by almost half. So it reduces by 50%. So the main conclusion was that it's really hard to make sense of results which people have not experienced, especially when you're using stated preference surveys. And driving simulators, virtual reality, helps kind of bridge that gap. So that's me. Thank you.
Oh, okay, thank you. Thanks so much, Vinayak. It's great. I mean, the diversity of work that's going on is unbelievable. It's fantastic to see it all come together. Now, last but certainly not least is Anne Williamson. Again, Anne's someone that I've known for a very long time. In fact, she was one of my mentors very early on in my research career, I think on the original capacity building grant. So Anne's the Director of Transport and Road Safety Research at University of New South Wales. So welcome, Anne.
Thank you very much. Thanks. Look, I'm conscious of the fact that it's 5 o'clock, it's Friday afternoon, and it's a bit chilly in here. So I'm going to really race through these, but I'm going to keep talking. I'm not going to get you to read the slides. I'll point to the bits I want you to read, because I just want to tell you the story, right? What I want to talk about is some new research that we've been doing for the last 3 or 4 years, looking at research on normal driving, trying to get a bit of an idea about whether or not by looking at normal driving we can actually learn anything more about preventing crashes than we already knew before. We hope we can. The traditional focus in road safety is to look, and any safety, I put road in brackets here because it's true for safety, that as you go and look at the failures, you go and look at the sad consequences, the unintended outcomes that we want to prevent, and that's what we study. And it has served us well, there's no doubt. It's been useful for explaining the circumstances and trying to understand a bit more about who's involved and that sort of stuff. But that is the way the focus. There are limitations to that, and we know them. We acknowledge them when you sort of prod us a bit and we say, oh, yeah, it is true that we don't know much about exposure. We don't know much about how often the precursors actually occur, the things you think are the cause of the crash, but how often do they happen but not cause the crash? I mean, what can we have no information about questions like, well, what do people do when they're normally driving? How often they actually take risks and don't have sad outcomes? And how do they avoid sad and unintended outcomes? And these are kind of important issues that probably could be quite useful to learn about. Fortunately, along came in 2005, I think, yes, the Virginia Tech took a very bold move with quite a lot of money, by the way, and did their 100-car study, which many of you have already heard about, I'm sure. There's been quite a reasonable amount of stuff published on it, but Tom Dingus's report came out in 2016. All they had done was to instrument 100 people's cars for 12 months and looked at how they drove. They videoed circumstances of the driver. They had instruments all through the vehicle, so they knew where they drove, when they drove, how they drove, etc. And it actually is providing new information. Certainly BTTI has been interested particularly in looking at safety outcomes as a result of these just normal driving. And the particular items of interest I think that they've showed in their very first work was that certainly there are big individual differences in who crashes. The likelihood of crashing, about 35% of drivers in their cohort, the 100 drivers, had at least one crash, but they found, very surprisingly to them, and I think probably to many of us, that 14% of those 100 drivers accounted for at least half of the crashes. So there's no doubt that there are people in our population who are more prone to crashing than others, and that's something that whilst we might have thought about it, and we do have some data on this, this kind of data is actually giving us some rather convincing evidence that individual variation may be something we need to at least put back on the agenda. Also, they found that there were very high numbers of less severe safety outcomes. They had 761 near crashes and over 8,000 safety incidents over that 12-month period. Lots of safety critical kind of data to look at. Since the 100-car study, there's been a proliferation of such studies. They're going on in Europe. The U-Drive project has just finished. I went to a meeting in June where they talked about the at least just tickling the data, because the trouble with this kind of study is you do generate an awful lot of data. The US has done with 65 or $66 million. They've been able to do the SHARP 2 study, which is just over 2,000 drivers studied for 2 years. There's studies in Canada going on, there's some in China, Japan, etc. And they're not all the same. And they're certainly starting generating useful information. A couple of years ago, we put up the idea that maybe we should do an Australian naturalistic driving study. And the question, I guess, was raised, well, why should we? There's certainly evidence that country and even regional differences like population density structure, and there's a whole range of reasons why countries might differ and crashes might differ. So that's one reason why we might want to do an Australian naturalistic driving study. But also, we don't really know about whether these international studies, as useful as they might be, we're not sure whether you get the same results here. So the real reason we decided was that, look, we haven't yet explored many of the high profile and often intractable issues that are still year upon year in our national road safety strategy and our state strategies as well. And maybe naturalistic driving data is going to give us some insights that we didn't have before. Questions like, well, how do people choose their speed choice? How often do they go over the speed limit? When do they do that? In what kind of conditions and circumstances, etc. And certainly in Australia, we have different, our society is different, our road rules are different, the way we deal with driving is different, so that these facets are likely to threaten the validity of just saying, oh, look, we'll just take the US data and apply it here. So we decided we would do a naturalistic driving study. We were particularly interested for a number of reasons. We're particularly interested in issues to do with getting better information about exposure. I don't know if you've ever tried to get some idea about the denominators, that is how much people actually drive. You find in Australia we have terrible data. It's largely made up, really. It's extrapolated to death, and it isn't really useful. Sorry for the, it's on video, isn't it? Sorry, available data. But let's say, I mean, we have got problems. This kind of information is going to give us, this kind of data is going to give us information about when people drive, how often they drive, and so on. And it really is an essential part of the information we need to develop good road safety strategies. Because, yes, we can say these things happen a lot, but and there are crashes, but they happen a lot. They're more likely to be crashes just because of exposure, and the conclusions we draw may well be spurious. It's also important for us to have some normative data and just information about how people drive. We make a lot of assumptions about risky driving, but there's a lot of driving out there that's just normal driving that is risky. We need to know a bit more about that. And that's really important information for not just policy, but the sort of stuff that I just heard about. I mean, autonomous vehicles, the kind of vehicles we're seeing actually out there at the moment that we're starting to have injected into our road system, many of them are not actually designed around what normal driving is like. And many of the things that are introduced in autonomous vehicles are also present a problem. This kind of data is just starting to be used in designing better driver assist and autonomous technologies. Similarly, we're interested in violations. When do people not comply with road rules? Most people do comply, but when don't they? Who doesn't? Individual variation is likely to be an issue and so on. We do need to understand better about driving risk, because in deciding what to do to try and make things better, this is the sort of information we need to have. And we also need it just to validate some of the data we have from less normal driving-related data sets. So we actually have established the Australian Naturalistic Driving Study. Many of you probably already know about it. It involves a whole bunch of people. There are 4 universities, Queensland, QUT, UNSW, Adelaide University and Monash University, all involved. ARC have contributed money. Transport for New South Wales have, Vic Roads, the TAC, and there's a bunch of groups who are involved. Sorry, you were supposed to be looking at that while I was talking. Anyway, too much on it. Lots of people there that you know. We're about to finish. Yay. 360 drivers. Their normal vehicles instrumented for 4 months each. We've got half are in Melbourne, half are in Sydney, half in 2/3 in regional areas or thereabouts, and the remainder the other way around, 2/3 in cities, the remainder in regional areas. We're interested in experienced drivers, so you had to have a full licence. We're not interested in this study in diluting the sample and looking at young drivers. As you'll see in a minute, we're hoping we're going to extend to that. But it was just looking at what people normally do when they drive. We had a bunch of equipment, and I'm not going to talk a lot about the kind of equipment we've got, but what it does, we're using the same equipment that Virginia Tech, who did the first 100 car study, and the Sharp 2, the 2,000 driver naturalistic driving study, we're using the same equipment as them, and we're able to look at things like what the driver is doing, the behaviour of the vehicle, behaviour of road users around the vehicle, and how the vehicle and the driver interact with the context. The measures we collect, just briefly, we have a data acquisition system, that is the Virginia Tech VTTI, what they call DAS units, data acquisition systems. We have 110 of those that are rotated through the vehicles over the 2 or 3 years we've been collecting data. We have a Mobileye system. Many of you possibly know about Mobileye. It's an add-on, an ADAS system you can put in your vehicle. It's been used to validate some of the data we're getting from the Virginia Tech vehicle materials and instrument. Seeing Machines we've got about 15 or so Seeing Machines driver vision systems that we're hoping are going to give us some insights into issues to do with fatigue and drowsiness and alertness while driving. And we collect a lot of information about the driver as well. So there's a lot of demographic information about who they are, what they're like, psychological, cognitive, physiological outcomes and so forth. Now, this slide gives you a whole lot of information which, if you're interested, I'm very happy to talk about later, but it's too much. It's just the sort of information that's being instrumented. The Mobileye also, I'll move on. The data that we're collecting, we will have collected by the end of this nearly 60 terabytes of information on these drivers. It's a huge amount of data. We're in the process of setting up a database to actually house that and make that data accessible. The data actually goes from, we send it upline to Virginia Tech, who clean it and basically basically clean it and send it back to us we've been getting it in waves, and we've actually been able to start doing some data analysis with it at the moment. And the aim is to have a data analysis group already available. The differences of our focus on the Australian naturalistic driving study are basically three major ones. First of all, that we are not necessarily focusing on crashes. We are really interested in normal driving. What do people actually normally do? Well, how do they avoid crashes? How do they minimise risk? How do they modify their driving to adapt to situations of increased risk? And those sort of questions. So what do drivers do when they're distracted, fatigued, when speeding, and so on and so forth? We're interested also in just experienced drivers doing normal driving, and we are very interested in this issue of individual variation, because that is something that's already coming up in the data we've looked at already. It certainly came out of the earlier studies that are being done and are being collected now, but certainly these naturalistic driving studies are giving us much more information about the range of normal. The current status of the study, and this is my last slide, we will be finished by Christmas, and we're very excited that the data is going to be available. It's coming back to us in waves. As you can imagine, there's a lot of data cleaning. It's taking some time for the data to be cleaned. But in waiting for that data, we've got about 2/3 of it here in Australia, and we're working on the establishment of an ANZ data repository in Australia, which the aim is to make available for ongoing data analysis to people who are interested in this kind of data. As you can imagine, the sorts of research questions with this kind of data available are only limited by our creativity. I mean, every time I think about it, I can think of new things that we can do with the data and new questions we can ask, which will help us answer more questions. The sort of things that we've been looking at so far, I'm particularly interested in real driving exposure. And the really interesting finding we're getting is that when you look at these 360 people, they mainly do short trips. We have a lot of people just ducking down the shops, going to work, maybe once every 2 weeks, perhaps. I'm making this up, but very infrequently they do longer trips. And it's suggesting that a lot of the driving that we do in our lives are for short trips. That's likely to change the way we think about, exposure and things like that. And maybe it also might change the way we think about how risk we take. Oh, just duck down the shops, and don't worry about my seatbelt, or it doesn't matter if I speed down this section of the road, and so forth. I mean, these are the kind of questions that we really are going to be able to answer. We're also currently looking at distraction with Transport for New South Wales and Centre for Road Safety. We've been looking at about 60 to 70 drivers worth of data, just attempting to look a bit more about what happens when people take their eyes off the road for 2 seconds or more. Safety critical behaviour, yes, but what is actually happening to outcomes? And we're studying that at the moment. We've almost finished and about to produce a report. And the very, very, very exciting thing is that we've actually managed to pull together a proposal to do a similar study looking at a naturalistic driving study of young drivers. This, I think, is one of the most exciting things I've been involved in. I think we're attempting to look at what happens in the first 6 months of driving for people who come onto the road in the very first week of driving. What actually happens? How is it that their crash risk decreases, which it does in those first 6 months, but we have no idea currently about what actually changes. This study is going to, if ARC will give us the money, because we've certainly got some funding partners who are prepared to also put in some money. We're hoping we're going to be able to answer questions like, well, what is it that we're doing right to get driving to improve over those 6 months? But what actually changes quickly, what doesn't change quickly? How might we change the way we train, and how might we change the way we manage novice drivers? Because as we know, they're certainly the ones of highest risk on the road. Lots of interesting things to do with this data. And again, at the end of that particular project, we will have a repository of data that can be analysed and pursued and looked at for some years to come. Thanks very much.
Thank you. I mean, that's phenomenal. If I was on the committee, I'd fund that, Anne, for sure. Yeah. Fantastic. That's just, I mean, I think we've had such a great lot of presentations here. Thank you for Andrew and Alison from the US and Canadian work. And I mean, that's incredible, and it's really good to hear about it. Bernard from the fantastic work that Transport for New South Wales is doing, the Centre for Road Safety, around all the data linkage. And then all our fantastic researchers come. I mean, I'm sure everyone's going to agree the quality is just phenomenal. The amount of work that's happening in here, and really, I think it's leading. It really is internationally it's fantastic work. That's all I can say. I'm going to stop right now because I know everyone wants to finish. Thank you, everyone, for coming. Thank you if anyone's listening online, and I hope none of us have revealed anything confidential to any of our, millions of people listening to our live YouTube stream. Thank you.